All right. This is really casual, guys, okay? It's a great topic, and it's a really hot topic. I just came back from Toronto, and I was with the president of the Association for Dental Implant Auxiliaries, Lynn Mortilla, who we cited in some of the slides here. And she was talking about how this is kind of the biggest topic right now when it comes to implant dentistry. As many of you know, implants are the fastest growing area in all of dentistry and medicine today. And people talk about implants lasting a lifetime. They've got beautiful custom componentry, and we'll show you some of that stuff as we get into the lecture. But it's really important that we all, as dental practitioners, and more importantly, the hygienists in the room, you guys are practitioners as well. I always say patients don't listen to us, the doctors. They listen to you guys. So you guys should really commend yourself for attending. And it's a really great opportunity for you guys to learn about how you can benefit our patients that receive implant and all dental therapy. It's great. I'm really proud and pleased to have you guys here. With that being said, this was a hot topic when I was out in Toronto, and I'm actually, I just got asked, I think, to do a similar presentation out in Disney. I just don't know if I kind of like going on the roller coaster, so I don't know if I'm going to speak there. But in any case, that'll be, it's quite interesting, and it's a big thing to talk about. How do we ensure that these things do last a lifetime? You can have you can go to a cardiovascular surgeon. You can go to an orthopedic surgeon, and any surgeon or any doctor will do stuff and give you a new heart, give you a new knee. But you as the patient have to ensure that things last, and there's follow-up and maintenance that's required in all aspects of dentistry and all aspects of medicine. So it's important that we educate our patients on what it is that we need to do to make sure that these things do last a lifetime, and we're going to get into that today. Before I start the presentation, I'm just going to let you guys know, I want to thank the people at Grotto here. These guys have been great. They've got great food. We host a lot of our presentations and seminars that many of you have attended here. And they're going to be serving dinner throughout the presentation, so feel free to chit-chat, get your food, eat, enjoy. If I bore you guys, eat some more dessert, more bread, whatever. Hopefully I won't, and I hope you guys will really enjoy what we have to share with you guys tonight. So I'm going to start off by first introducing some of the sponsors for the evening. As you guys know, this is a really great event, and it's a great venue, and there's a lot of people that went into helping us put this together. I'm going to start off over on the far left corner. It's Gordon Jennings. Gordon, I actually met when my back started giving out, and he's got an awesome saddle chair over there. And if you guys haven't had an opportunity to try it out, you need to try that out. Gordon Jennings is with Gordon Jennings Dental Sales, and he sells a lot of various instruments through Nordent. Basically anything you need in your office, he's got, and it's a good opportunity for you guys to talk to him. Mark Buckholz is with Noble Biocare. That's Mark. Thanks, Mark. We use Noble Biocare and BioHorizons. I think they're the two best products that are out there. We try and use the best for our patients. And Noble Biocare is one of the leading implant providers in the world today. Anytime you guys have questions in terms of restorative or impression-taking techniques, anything you need, Mark and my BioHorizon reps as well, you need to ask them, and we'll put you in contact with them. And these guys are very knowledgeable, and it's great to have them here helping sponsor. Mira Albert, way in the back with Brush Pediatric Dentistry. Mira is just opened a brand new, beautiful, gold standard pediatric office in Hinsdale. I asked Mira to come personally because I took my kids to her, and it was just a tremendous experience. You can ask my wife. Actually, I didn't take her. My wife took her. But anyways, Mira, my kids couldn't stop raving about what a great experience it was going to the doctor. And if you guys don't work with a pediatric dentist or haven't had the opportunity to ask a pediatric dentist questions or work with one, you definitely need to talk to Mira, because not only is she knowledgeable, but she's just got a great patient demeanor. I don't know how she put up with my kids. So if she put up with my kids, she can probably put up with all of the other children, patients that you guys see. So thank you, Mira. And she's in the back over there with Brush Pediatric Dentistry. I'm going around the room. So I've got Northwestern Mutual Financial. We have John Green and Vince Silva. John and Vince do a lot of personal financial planning. I've been introduced to them through several doctors that I do work with, and just in talking to them, they're real knowledgeable. And in this day and age, it's really important that we provide not only for ourselves, but we think about our future. So now and the future and our children's future, and it's important you can talk to them. And we just did this at our practice in terms of retirement planning, benefit packages for your employees who do make the practice go. And I think it's a good opportunity to talk about putting some money away and tax savings, and these guys are the guys to talk to because there's some really new, neat things that we can do and I had no idea about. And it's great talking to guys like John and Vince in terms of what you can do to help yourself and help your other team members. Where am I? I'm going over to Care Credit. So we do a lot of implants, and people say implants are expensive, and how do we afford them? Well, we have zero money down, interest-free financing. I feel like a car commercial. Care Credit's the best. They let them chase the patient's money. They apply, you apply right online, and patients have the ability to get approved within a matter of like 30 seconds. And once they're approved, you got your money the next day. As the dental practice, you don't have to worry about sending billing statements, whatnot, and let Care Credit handle the rest for you. And we do a lot with Care Credit. That's how we do about 1,000 implants a year in our office. And my treatment coordinator, you can ask Dana Hancock, who is my lead treatment and implant coordinator. She's on the phone, and not even on the phone, online with them 2, 3, 4 times a day. They're really easy to work with. If you have a patient you start a treatment on, there's been a change in the treatment plan, and you need to do a little bit more for them. You put a call into Care Credit, they'll up it over the phone. It's really great to work with them, and it makes things a lot easier. It's a lot less paper in terms of billing and statements that you have to deal with as well. I'm a big believer in outside financing for our patients. BioHorizons, they're over there eating, but their booth is over there. This is my good friend Scott Lynch and Ron Dubois, great guys, very knowledgeable. I had the pleasure of meeting Scott about 8, 9 years ago. Scott, actually, the great thing about Scott is he's my BioHorizon rep, and many of you had the opportunity to work with him. But not only is he an implant rep, but Scott, before he joined BioHorizons, was an independent consulting dentist on marketing and growing your practice. And in terms of implants, aesthetic dentistry, cosmetic dentistry, whatnot, and he is a very knowledgeable guy to talk to. So not only can he come educate you guys in terms of dental implants, but he can also come bring lunch and talk to you and your team and your other team members in terms of case presentation, getting cases accepted. He's unbelievably talented and very intelligent. He's given me a lot of great pointers, not only in terms of being a better surgeon and helping you guys be better restorative doctors, but in terms of educating your staff on how to make the overall patient experience better. Great guy. Thank you, Scott. And Ron. Ron's a little sexier than Scott, but that's okay. Ron is the regional manager here with BioHorizons, and Ron, I have the pleasure of Ron's company tonight, and these guys are good guys to work with as well. Lastly, we have Lindy Peterson from Lindy Peterson from 3M. I missed one. We'll get to him. Lindy Peterson with 3M Dental Supplies. It's funny, everyone always asks me, what do you recommend? What do you provide in your office? What do you order? And I don't know. I just do the surgery, actually. But my hygienist and my team work a lot with 3M in terms of the different aspects of dental preventative products that we can provide to our patients, composites that we use for our temporaries. So we get a lot of that stuff through 3M, and they've been generous enough to help sponsor this evening. Definitely talk to her. She's got some new things in terms, she just mentioned to me about cord retraction, some new flowable composite materials that are really outstanding and hold up like traditional composites, but a lot easier to use. And she just introduced me to some of those products. So we've worked with Lindy in the past, and she sponsored some of our events, and thank you, Lindy. And last but not least, my good friend, we have Tad Fries. Tad's in the back, and he's with Rocker Dental Lab. We've been working with a lot of different labs just because as a surgeon, I do more of the surgical stuff, and I work with a lot of different lab technicians, and I've recommended different labs to different people for different reasons. And in the last about 6 months, I've become affiliated with Rocker Dental Lab, and you guys can talk to some of the doctors that work with them. They do outstanding work. They're timely. I have patients that come in and they want to get treatment done yesterday, and I call Tad and I'm like, listen, man, you got to help me out, make this flipper, get me the stent made, whatever, and they work with us. They're located in Wheaton, which is close by to the because we're in Oak Brook and in the Midwestern suburbs, and they're easy to work with, they're reasonable, and I've worked with a lot of different labs, and the best, Tad may not like me for saying this, but they're very reasonably priced. So maybe, I don't know, Tad, don't raise your fees, but they're good. They give you great product at a very fair competitive price. I have to say that about them. So I want to thank all of our sponsors. I'm trying to drag things out because here comes the food. So I'm going to allow these guys to do their thing and start handing out the food. It looks like the first course coming. And without further ado, we'll get started on the presentation. So once again, can everyone hear me okay? I'm not too loud. Dana, I'm good? We're good? Okay. Dr. Grandinetti, you can hear me okay in the back? Oh, last table. This is a round of applause to these guys. These are going to be the future of our field. Table over there, third and fourth year dental students from the University of Illinois. And I commend them for coming out because these guys want to learn. And my cousin is actually a fourth year dental student. And he mentioned to me that I mentioned to him I was giving this presentation, and he asked if some of his colleagues could show up and just kind of learn, because they're learning a lot about implants now in dental school. And what's happening is, I don't know what's happening. Oh, Michelle's doing something. Okay. What's happening is they're asking a lot of questions, and I just had about a 10 or 15-minute conversation about the different aspects of implant dentistry. And I really commend you guys, because when I was a student, I was just more worried about where the quarter beers were, or nickel beers were when I was in school. So, but you guys coming out, that's pretty cool. And it's a great credit to know that the future of our dental field is in good hands, and you guys are wanting to learn about this stuff. Because as we know, implants are the hottest topic in dentistry. So fourth year dental students, round of applause to University of Illinois Dental. Thank you guys. Yay. All right, so you guys are doing okay. Sir, the guys, the wait staff, you guys are okay? Getting through and no problems if I talk with help with. I'm not interrupting you guys serving the food? Good, excellent. Just making sure, just in case they had to ask questions or something. I think they've taken the orders. Oh, Cindy's giving me the evil eye. There's paper on the table for your continuing education. It's important that you guys sign that paper, get that to us at the end of the evening so we can get you guys your CE for the evening's lecture. All right, so please make sure you fill that out. All right, so without further ado, let's get rolling. Once again, this is very casual. Any questions you may have, raise your hand, interject, throw something at me. I'm good with anything. Just want to make sure you guys feel free to interject. I know it's a large room, and sometimes people feel shy. So I'm going to try and make it interactive and talk to, call on some people as well. All right, so tonight's topics of discussions. We're first going to talk about, just a basic overview about what dental implants are. As many of you have been to some of our study clubs that we host with the practice, we do a lot with implants, and I just want to go over a quick couple slides on the benefits of implants and the basics on why they can really benefit your patients. We'll then get into the heart of the discussion, which is, how do we evaluate implants? And what's the difference between a natural tooth and an implant? We'll then talk about the proper techniques in terms of evaluating, doing a proper dental implant assessment. Based on that implant assessment, we can then, we can help talk about the health scale of implants. In periodontal therapy, we've got a health scale of, excellent prognosis, good prognosis, fair prognosis, guarded to poor, et cetera. The hygienists are all nodding their heads, and I think that they're saying, that's something we talk about in dentistry, about prognosis of teeth. Well, we've got the same type of prognosis for our implant patients as well. Big topic for a lot of doctors, and we get calls on this all the time, is like, once we determine the implants, the health of the implant, we then want to talk about some of the common problems that we can find in implant dentistry. Things that if you do a lot of implant restorations, you will encounter these problems. I mean, this is just part of it. And it's important that you know how to handle these problems. And some of them, you're going to work with us, the surgical office. Some of them you're going to handle in your office. Some of them the hygienist is going to handle. And we're going to talk about how to differentiate and evaluate and, when you should do what. Lastly, the big part here, the best part is, how do we prevent these things from happening? How do we, as dental practitioners, dentists, specialists, hygienists, practice managers, staff, how do we help educate our patients and treat our patients so that none of these things, so implants can last a lifetime? And that's the best part of the whole presentation, in my opinion. So we're going to get into it. Once again, any questions, feel free to ask. I will be trying to call on some people, keep you guys on your toes. So benefits to dental implants. Number one, we all know when you lose a tooth and don't replace it, you're going to lose the bone. So dental implants, one of the best things they do is they maintain the bone. We've seen slides in the past about how if you have a dentulous patient, a patient that's upper and lower denture, when they take their teeth out, their face sinks in. And then they say that their dentures don't fit anymore. It's not because the dentures don't fit, it's because the bone is atrophying and the dentures don't change shape what the facial structure does. Implants prevent that from happening. Number two is, when you have implants, you can increase your stability, your comfort, increase your self-confidence. The implants are the best tooth replacement option out there to improve talking, smiling, chewing, self-confidence. We have patients that can't enjoy a glass of wine because they have an upper denture and the palate's covered. You have taste buds on the roof of your mouth. People don't like to drink wine and have metal in their mouth with partials. They don't like to chew a steak and have their teeth digging into their gums. They don't like to talk and have food getting caught underneath their bridge and have a whistling effect. So implants can improve all that. You don't have to damage your adjacent teeth, and with proper preventative measures, these things can last a lifetime. Hence, in my professional opinion, and the opinion of many that besides myself, these things are the most cost-effective things we'll do in dentistry, because if done right and maintained, you don't have to change them out. All right, so some of the misconceptions, and just again, a couple quick overview slides, with dental implants. All right, so we have patients that come in. I had a kid that came in, and I have patients that come in. I had a kid that came in yesterday, had trauma to his front tooth, similar to this situation. This patient had a root fracture, horizontal root fracture, young girl, 18 years old. This is her on Monday. This is her Friday, and she went to prom. She was the homecoming, or prom or homecoming, a spring dance. She was like the spring queen. So we were able to take out a tooth, place an implant, give her a temporary abutment and a temporary crown, and this is her Monday, and this is her Friday. We were able to preserve the aesthetics of the smile line, preserve the papilla, and do lots of neat things. So what does that show? Well, number one, it shows that it can be done. It shows that it is not expensive, because insurances do cover dental implants now. Cindy Edwards, I've been in dentistry since 1997. I've never, in 15 years of practice, met anyone that had 1/10 of the knowledge. I have doctors in this room that are personally calling her and asking her to come into the office to help out in terms of helping with insurance benefits and in terms of billing and questions and whatnot. And one of the benefits of our practice is we will help you guys in terms of educating you for case presentation, marketing with Andrea. She's gone out to some of your offices, and also just answering questions in terms of insurance benefits and coverage. Implants are covered now with dental insurance. It's a great thing. And the big thing here is people don't have to have a flipper in their mouth for 6 months or a year. We can take out a tooth and put a new tooth in their mouth. The cosmetic tooth can be delivered in their mouth the same day. How is all this possible? Well, the biggest, hottest topic in dental diagnostics is 3D imaging, and we have a CT scanner in our office, and I would not touch an implant case without a CT scan. I believe it's standard of care. It's, because I think if you've got the technology, you want to have a GPS of the skull. With the 3D X-ray imaging, we are able to virtually do the surgery in the patient on the computer prior to doing it in their mouth. It's like taking a test in high school. If you got the test a week early and were able to take it at home with your textbook and your notes, you still got to take the test, but you know all the questions. You're going to fly through the test. Hence, you're going to take the test quicker, you're going to be more confident with that test, and you're going to get a better result on that test. In the same way, if you're able to virtually do a surgery, as you can see here on this X-ray, we're able to place the implant, we're able to determine the bone density, figure out the exact size of the implant without perforating that maxillary sinus, determine exactly in extraction sockets how to take out the tooth in an axial view to see the diverging roots or converging roots, determine where the bone is. We can get a lot of information on the front end, avoid vital anatomical structures like the inferior alveolar nerve, the maxillary sinus, adjacent teeth, etc. And hence we're able to have a more predictable result, which is therefore saves your patient time because you're more definitive and efficient in the surgery. You're more predictable. And it's a great case presentation tool as well. So with this virtual surgery and 3D imaging, we are now able to do things that we couldn't do before. We're able to see a patient like this, take out her hopeless teeth, give her 4 implants, and give her brand new teeth. This is 8 o'clock. This is 10:30 in the 8 o'clock a.m., 10:30 a.m. Now, there's work on the front end. We work with a lab like Rockert Dental Lab. We take impressions. We have temporaries pre-made. We then retrofit the temporaries over the implants. But if you work up the case right, take the proper diagnostic models and 3D imaging, you're able to do this in 2 hours, get this patient in, sedate him, get the teeth out, implants in, and give him a brand new smile in literally hour and a half procedure. This is one of my favorite stories, and I just used this case as an example because it's an overdenture case. Another hot topic in implant dentistry is patients that have dentures that, with palatal coverage or lower over dentures that don't stay in. Any of you guys in here that are motorcycle people, bikers, there's a big motorcycle convention up in Sturgis. They ride their bikes. This guy is about a 6'4", 240, if you saw his face, which we cut off for HIPAA purposes. But he actually came to me after he went to Sturgis, and he was biking on his motorcycle, and he was screaming to his friends as he's biking, 60, 70 miles an hour on the highway. And as he was screaming at his friend, his dentures went flying off on the side of the road. And so literally him and his it looks out of a movie. These guys are huge. He showed me pictures. These guys are monsters. They're digging through the side of the road looking for this guy's teeth. Found his teeth, put him back in, came back to me, and he's like, listen, he went to his dentist. Dentist referred him over to me, and he said, look, I need to keep my teeth in my mouth. What can I do? Well, we were able to get him 4 implants, put 4 locator attachments in. You need 4 on top, okay? 2 on the bottom, 4 on top is recommended, all right? Cut the palate out so now he can taste his food. And these things, he said, I can bite the bark off a tree. He said, I can bite into a beer bottle, open it up, I can bite the bark off a tree, and I don't know what he did up on, but he was able to scream at his friends on his motorcycle and his teeth didn't fall out. So he was very, very pleased. And that's the true story and the type of stuff we see in dealing in dentistry. So you guys will have this. You will have patients that come in and you will have a grandmother or a grandfather that wants to give a toast at their granddaughter's communion or grandson's communion, and they're going to say, my teeth almost fell out when I was given a toast. Or they're going to be embarrassed to speak at their daughter's wedding because their teeth are going to come out. You can avoid all of that with implants and overdentures, all right? And this is one of the hottest topics and one of the fastest growing areas in removable prosthetics is overdentures, implant-supported overdentures. Talk to Mark, talk to Scott and Ron. These guys can talk to you about the locator components. In the past, you had to do crazy bars and it was really expensive, and now it's a fraction of the cost because they've got new components instead of those old ball abutments that many of you have worked with. I know I've worked with several of you guys in here. Mark and I have worked on some cases where they had the old ball abutments. They don't work as well. These things are great. Mark, we've done some numerous cases, and the locators are unbelievable. They give you the same retention as those bars at a fraction of the cost, and they're great. Ron, I've worked on, had the pleasure of working on some of Ron's family members, and would you say that the people that we've worked on with those overdentures have had some good experiences?
I could lift my mother-in-law up by her teeth.
I didn't want to say who it was, yes, but yes. And she could eat, and she was saying she went out for steak, and she was loving it?
My father-in-law has to actually help her get them out.
That's a good thing, right? You know, what we do for our loved ones. You see billboards on the side. Do you want to end up with your teeth in a glass? No, you don't want to see that. You want them in the mouth. But, I mean, these things are great, and they're inexpensive, and you can have patients that have dentures that are having problems. Work with your surgeon. If you do implant yourself, this is a great thing for your patients. And if the denture's like a year old, you can just retrofit that denture. You can do a reline. The lab, Tad, I know you're eating. You guys do lab relines within a day typically for denture patients. The denture's made in immediate extractions. You can take impressions on these implants, send it to the lab, and usually within a day you can have the teeth back. You don't even have to do anything in your office. I mean, you can do it in the office if you want. I typically say let the experts deal with it. It makes life a lot easier. And Scott and Mark can talk to you guys about how you can do that as well. Implant-supported fixed dentures. This is the patient. You hear about all on 4, 5, or 6. Here's the patient. This is where he presented to my office. Type 12 periodontal disease, generalized rampant decay, teeth that were not staying in. And one day we were able to take out his teeth, place 5 implants on the maxillary region, 5 implants in the mandibular region, give him angled componentry to compensate for the angles on the implants, to then allow us to fabricate fixed temporaries. 3 months later, we worked with our restorative doctor and a lab like Tad with Rockert, and you can fabricate a final prosthesis that's going to stay in the patient's mouth. Now, the thing to look at on this case here, there's a reason this guy's a dentulous. He hadn't picked up a toothbrush, I think, in 12 years, all right? When they get the implants, they have nice teeth and they're smiling and they look good, but you don't change habits overnight. As my dad would say, a tiger can't change its stripes. So the hygienists are shaking their head over there. What's your name over there? I'm sorry?
Me.
Pardon me?
Me?
Yes. Natalie, would you say that when you see patients with type 4 periodontal disease or type 12 periodontal disease, is this one I call it, do you think they changed you treat them with SRPs? Do you think overnight they improve their home care and whatnot? Don't you usually have to beat it into their heads?
Yeah, and they'll just say pull them.
Exactly, and we don't want that. So we, as dental practitioners, can give them great products. 4 implants and an overdenture, implant-supported fixed prosthetics. But it's important, write this down. The most important thing that we can do tonight is make sure we learn to educate our patients, because once we give them these implants, these are going to fall out of their mouth also if they don't pick up that toothbrush. So you got to beat it into their head. Don't touch the case. Go ahead. Question?
I'm sorry, give me a second. I just wanted to ask you, is there a certain way you prefer to restore, like the fixed denture, or would you rather do the 4?
There's a couple things that we look at in terms of recommending options for patients. One, you take them out and put them back in. All right. A fixed prosthetic appliance works really well for people that cannot tolerate things in their mouth. They come in and out. You have gaggers. This guy was a gagger. He couldn't keep his upper denture, and that's why he never went to a lower denture and just kept his dead teeth. He said, there's no way I'm going to keep it in my mouth. So if you have a gagger, all right, or a patient that has teeth and has never had a removable appliance, I typically recommend a fixed appliance. Now, it's typically twice the cost. This is about between myself and the restorative doctor, this is about a $20,000 to $25,000 case, per arch. All right, but if people can't kick things in and out of their mouth, or they've never had something going in and out of their mouth, it's a really tough thing to do. Hence, we place the implants and we'll lock the temporaries in that day. If, however, you've got grandma or Aunt B from Leave It to Beaver, I think it was, that she comes in and she's had a denture for 15 or 20 years, she's used to it. You're going to really improve her life by taking her from something with the full palatal coverage to something with no palate. It's half the cost, and it works just as well. The retention's great, and they're very happy as well. In terms of hygiene and maintenance, I recommend this. This is easier to clean. They can take it out, they can brush it, they can clean it. But it depends on each patient, so patients have different, you have to, when a patient comes in, the first thing you should ask, what's your chief concern? If you ever watch that show, Nip Tuck, they always said, how can we help you? Christian Troy, and I don't know what the other guy's name, I like Christian, he was the cooler one. But, they would always say, how can we help you? So you ask your patients, and that's the big thing. My dentures don't stay in and out. They fall, they wiggle, they wobble. Or they may say, my grandmother had dentures. There's no way I'm going to dentures. I can't keep things in my mouth. I'm going to gag. I can't do it. So you got to, it's dependent on each patient. Price-wise also plays into it. But the neat thing about it is you can take this patient, place the implants, and the foundation's there, and you can convert them to this patient a year or two later. Once that foundation's in, it's in. So it's like building a house. You don't always build a house, do the window treatments, finish the basement, and do the backyard all in the same year. You can do a little bit and grow from there. So I hope that answers your question, okay? But the big thing is the number one contraindication to anything we do in dentistry. What's the number one? You can't touch a patient if, well, I'm going to ask the dental students. Raj, where are you at? My cousin Raj, top of his class at U of I. What's a big contraindication to dental surgery? One of the largest contraindications to any dental treatment. Compliance. Compliance, hygiene, right? They don't pick up a toothbrush no matter what we do, it's not going to work. If these guys can't brush their teeth, you can't be doing implants on them, you can't be doing crowns on them, you can't be doing bridges on them. The number one cause for dental litigation is failure to diagnose and treat periodontal disease. And for dentists, not the dentists in this room, but there's dentists out there that are doing treatment on patients and not going over compliance issues. And hence, they're placing crowns and bridges and doing root canals on teeth when the patient's oral hygiene is hopeless. Hence, the case is going to fail. And the patients need to be made aware of that. So you got to inform them of that stuff. Good answer, Raj. You learned something in school. I'm glad you went to class. I got to tease him a little bit. He's like my kid brother. Just a lot of good stories, and I've got some slides in here that I'm going to tease him a little bit on as well. So that's what happens when you have a kid brother. He's my first cousin, but he's like my kid brother. He's seen me grow up. He saw me in school. Funny thing is, Raj has been to every one of my graduations. I don't know how he did it, but he had to go to my high school graduation, college graduation, dental school, residency. I've never been to any of his, I don't think I have I? So it's the advantage of being the big brother, right? So in any case, I did tell him I'd attend his dental school graduation, so I'll do that for you, Raj. But he's a good kid, and once again, I'm teasing him a bit, but he has seen me grow up, and I've seen him grow up, and he's a good kid. My wife loves him. She's his favorite. My wife's here. Hi, Sweta. How are you? Oh, special thanks to Sweta. I'm going to say it at the end. She helped put the whole evening together. So it's the better half. Congratulations, smile. The smartest people surround themselves with smarter people. So that's what I try and do.
And better looking.
And better looking, absolutely, right? Okay, so we talked about different types of implant restorations. We talked about removable, single tooth, multiple teeth, full mouth, fixed, and removable. All right, so basics on just the benefits of dental implants, okay? So now let's get to the crux of the presentation. In order to understand how to evaluate an implant, you got to understand the difference between an implant and a natural tooth. So there are differences, okay? There's many similarities. It's the closest thing you have to a tooth replacement is a dental implant. But there are some key differences that you're going to have to know and understand in order to help make sure these things last a lifetime and help educate them on how to take care of them. Help educate your patients on how to take care of them. So we're going to talk about, it's a great slide here talking about a natural tooth and a dental implant. So back to Dental School 101. 3 parts to a tooth. The crown, all right? 4 parts. The enamel, dentin, pulp, and cemental aspect of a tooth. All right? I failed Dental School 101. The tooth root is embedded in the jawbone. Connecting the tooth root to the jawbone is this thing right here called the periodontal ligament. You then have a connective tissue attachment of about 1 millimeter and an epithelial attachment of about 2 millimeters. So when everyone talks about crown lengthening and biologic width, 3 millimeters, that's where you get that. You got to have that 3 millimeters of soft tissue attachment. That's where the term 3 millimeters of biologic width, Gargiulo, 1964. It's the only study I remember because he was one of my teachers at Northwestern and they beat it into our head. And if you don't know that, you wouldn't have graduated from Northwestern in my specialty program. So 1964, Dr. Gargiulo, he cited that 3 millimeter of the crown lengthening and the violation of the biologic width. Well, so for a natural tooth, you have the biologic width due to that connective tissue and epithelial attachment, and then you have a sulcus of 1 to 3 millimeters for optimal health. With an implant, all right, you have the implant, which is a titanium tooth root replacement. Don't say I put a screw into your jawbone, all right? It is what it is, but you can say we take a titanium tooth root replacement, and that's where Scott and Mark are the best. Get them to your office. Educate your patients. Side note, write this down. People know what implants are today, okay? 10 years ago, if you said implant, you'd be looking at a woman's breasts. Honestly, that's what you would look at. But with television and social networking and social media and the internet, people, your patients are going to research and know what an implant is. You guys got to know what it is. You have to educate your patients. There's billboards on the highway. There's TV commercials, radio commercials. You guys should be doing these things in your office. It's standard of care. In the state of New York, it's considered battery, all right, if you don't offer dental implants as a tooth replacement option. You have to offer this to your patients. So everyone, when I do a lot of lunch and learns, and I've come out to many of your offices, and you all have pictures of cosmetic cases of veneers and of Invisalign and of bleaching. So when a patient asks about that, oh, let me show you this case picture. Let me show you this brochure. Have the brochures on implants, because what happens is marketing is it's the rule of 8. You hear something 8 times and then it sticks in your head. So you see the TV commercial 1 or 2 times, you see the billboard, you hear the radio ad, your friend talks about it, et cetera, et cetera. Then that patient is going to come into your office and then they're going to say, my God, my mother-in-law could benefit from her teeth wiggle and wobble. Have brochures. Scott, do you guys have implant brochures for overdentures and for single tooth replacement and all that you can provide to the doctors in the room? So if anyone's interested, Mark, you guys have the same as well with Nobel? Okay, so if anyone in the room is interested in getting information to have in your waiting room for your patients, talk to these guys. They'll get it to you guys. They'll get it to you guys, what, within 24 hours you can have it to them? All right, great. Scott, same thing? Make sure, because your patients are going to ask these questions, and you don't want them to think that you guys can't offer this to your patients. The hygienists are going to get these questions also. You got a patient that comes in, their partial's digging in, it's killing that abutment tooth. You guys got to make sure that you can educate your patients, and pictures are worth 1,000 words. All right, so sorry, back to the lecture. Implants, osseointegration, that's the term. The implant will actually osseointegrate to the jawbone. The gingival tissue that covers it, you might get about 1 millimeter of a connective tissue attachment on some of the new surface coatings at the head of the implant. Okay, but not really necessary, and you'll see on the next slide that the probe typically goes to the head of the implant versus the probe with the natural tooth will go to the top of the epithelial attachment. You have an abutment and then you have a crown. So best analogy I give patients is you have a coat hook. The fixture in the wall is like the implant, the hook is like the abutment, and then the coat or purse is like the crown. They get it every time then. So 3 components. Surgeon will typically place the implant, the restorative doctor will typically place the abutment and the final crown. It's a real simple analogy for the doctors, hygienists, and staff members in the room to help explain how an implant works and the basic componentry of implants. Write this down. The difference between an implant and a natural tooth is this thing right here, that periodontal ligament fiber. This is going to be really important to remember in terms of maintenance and preventing problems from happening. This is why you can't connect a natural tooth to an implant, because a natural tooth has a shock absorber, all right? An implant doesn't. So there's rigid fixation, and when you do a lot of implants in a patient's mouth, you got to get them in a night guards. You're going to have major issues with TMJ and whatnot because you don't have that shock absorber there. All right, does that make sense to everyone, and the differences between the teeth and an implant? All right, and here's a nice slide here. Michelle, thank you for pulling up the slide. This is where Michelle did her magic. Here's the probe hitting the top of the epithelial attachment. Connective tissue attachment of 1 millimeter, epithelial attachment 2 millimeters. Sulcus depth, probing 3 millimeters. Natural teeth, healthy tooth, you probe 1 to 3 millimeters is ideal. All right? You look for radiographic bone loss, and you look for bleeding on probing, okay? On dental implants, we're going to talk more about this, but the probe may drop down 7 or 8 millimeters depending on what? The height of that abutment. All right? You don't have an epithelial and connective tissue attachment. You're going right down to the head of the implant typically, so probe depths aren't as important. All right, and we'll talk about that in a little bit, but I just want you guys to understand the differences. Does that make sense in the difference between a natural tooth attachment and an implant attachment? Questions, comments, concerns? Got it? Raj, was I right? Was good? Dental School 101? Was that in the hygiene department you learned that, or was that in perio? Where did you learn this part? Oh, good. See, I remembered something. All right. The dental implant assessment. Okay, now that we know the difference between a natural tooth and a dental implant, okay, you want to be able to obtain baseline data, evaluate the patient, hygiene, etc. Contributing factors, smoking, poor oral hygiene, uncontrolled systemic diseases, etc. And we'll get into that. And then we'll talk about the health scale. So we could actually get you guys this. This is from the International Congress of Oral... Actually, this is from the... Lynn's going to kill me. This is from the Association of Dental Implant Auxiliaries. She's like, look, the ICOI gets all the credit, but we do all the work. That's the aspect for the hygienists who do all this evaluating. And this is a form from the ADIA we can get to you guys on how to properly evaluate an implant at baseline and take it forward 1 year, 2 years, and 3 years in. And we'll talk about the different aspects of the evaluation now. All right, so why do we collect baseline data? All right, when you do a crown on a patient or when you do a root canal on a patient, when the endodontist completes an endodontic procedure, they take a final x-ray check, correct? And why do they do that? Let's ask. Brainard, where are you at? Hi, Brainard, how are you? So when you do a root canal on your patient or when you do a crown on your patient or put a bridge on, do you typically take an x-ray upon delivery of the crown or upon completion of the root canal? For baseline, correct? And then sporadically, every 2 years, you take new x-rays and you want to compare to see if there's any changes, correct? Well, would you do the same thing for an implant, you think? Oh, good. I'm glad you'd agreed. Thank you. Dr. Yanis is also a fellow at the International Congress of Oral Implantologists. He attended the meeting with me in Toronto. A round of applause to Dr. Ballesteros and Dr. Brainard Yanis. They also received their fellowships. Round of applause for those guys. Congratulations, guys. That's a big honor. Thank you, Brainard, for commenting. So you want to get baseline data on anything you do in dentistry, all right? So, and that's so you can compare it if there's a problem down the road. When we do implants, we ask your patients to come back for a final crown check, we call it. We take x-rays. And a lot of patients ask, why are we taking all these x-rays? I want to have an x-ray so I can compare if there is a problem. We'll get into the problems of where they're at, whether they're completely restored, to where they're at and when the problem develops so we can compare the issues, okay? You then do the patient assessment, okay? You want to update the health history, pharmacology, changes in the medications. Are they taking calcium channel blockers? Are they taking anti-seizure medications? Are they taking other medications to suppress autoimmune disorders that can cause gingival overgrowth? Are they taking any medications that can decrease salivary functions? Are they smoking? You know, you want to look at those contributing factors. Parafunctional habits you want to look at. Take all that and review that at your assessments. Hygienists, it's really important that you guys do this because those doctors don't always do this. We don't see the patients for routine checkups. It's important you guys document this stuff, okay? You then look at what Raj so eloquently stated, the most important thing, that home care. How are they with their professional and home care maintenance? Are they brushing? Are they flossing? Are they spending 5 to 10 minutes a day in their mouth to maintain what you guys as dentists and hygienists have done for them? All right? So you document all that stuff, all right? You then evaluate that peri-implant tissue, okay? So you look at the tissue around the implant, basically. You want to look at what the healthy tissue looks like. Do you have keratinized tissue around the implant? Not always necessary, but preferred, okay? Is there spontaneous bleeding? Is there a spontaneous discharge, exudate? You know, probing is not a big indicator. I use a probe only if I see an issue. I don't measure probe depths because, once again, I can have an implant 3 to 4 millimeters sub-G for aesthetic purposes, and then I might probe 5 or 6 millimeters when I probe down to the head of the implant. Okay, because of the 1 millimeter of connective tissue attachment, the sulcus steps, and you can probe 6 millimeters at the interpapillary spot and 3 millimeters at the facial aspect. So it's not really a good indicator. Now, what it is a good indicator for is when you probe and there's a spontaneous bleeding or discharge that comes out with that probe. Write this down. If you're going to probe patients, number one, plastic instruments, okay, around implants. We all know that, okay? Write this down too. Probe your natural teeth first. Take that back. Probe the implants first, and then probe the natural teeth if you're going to use the same probe. Because you don't want to take the bacteria from the natural teeth and infect the implant socket. So that's real important to know. Probe implants first, then probe the natural teeth if you're going to use that same plastic probe, okay? So we look at the tissue around the implant, and you look to see, is there problems? Is the tissue red? Is it swollen? Look, this is healthy keratinized tissue here, 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 and all of a sudden around this implant there's not. So now we know there may be an acute problem that's developing, and you can look right there and see a little cement. That's typically the cause of the problem. All right, we'll talk about that when you have problems determining the causes. Next thing is the x-ray evaluation. So now you've looked at the baseline patient health history. You've looked at the tissue around the implant, the contributing factors. Now we're going to do a radiographic assessment. It's really, really, really important that we take proper x-rays for implants, okay? Because you've got to make sure you use those paralleling. You know, I always recommend those paralleling rings. Gordon, I'm sure, and 3M have those. You can get them from them. They're the best things possible. I'm insistent that my staff and my hygienists use rings to take x-rays because you want to make sure that x-ray is dead on to see if there's a problem. Okay, and I'll show you an example of why in just a second. In the first year of treatment, the International Congress of Oral Implantologists recommends that you take x-rays around an implant every 3 months. This is another reason that you want to do implant maintenance, okay, the first couple of years with implants, all right? After the first year, you should take a radiograph around an implant once a year. This is by the International Congress of Oral Implantologists. Studies are cited down here, okay? This is keys to success, maintaining long-term health of implants, all right? Radiograph should be evaluated for the presence of radiolucencies and acute excessive bone loss, all right? Acute. And we'll talk about stability of implants, and bone loss it does occur, and it's not the end of the world, but you got to take everything into consideration, all right? And we talked about here, you're going to have a little bit of bone loss around implants just from the surgical trauma. So it's normal to lose 1 to 2 millimeters of bone in the first year, and it's not the end of the world, down to that first thread typically, okay? This is why you want to use paralleling cones, okay? This is an x-ray that was taken, and this x-ray is bad because you can't see the threads. When you take x-rays of an implant, you should see the threads. If you don't see the threads, this dentist took an x-ray, the angles were off, and he thought those crowns were seated. You can see here that that's the implant, the abutment's down, but the crown is not down to that abutment. And because the x-ray was off, and I didn't have a copy of his x-ray, when the patient came in, there was irritation in the tissue, we took an x-ray with paralleling cones, and we saw the threads, and we could see that these things weren't down. This is what you want to see. Make sense? Also, you want to make sure the abutment's down. So take the x-rays right to make sure that that abutment's seated. If the angulation is accurate, the radiograph clearly shows the threads. Blurry threads indicate angulation and accuracy. Write that down. If you don't see the threads, it's a bad x-ray. And then you could have this issue, and now you're going to run into problems. Okay? The implant abutment connection should appear as clear line right here, straight across. You shouldn't see a space. Okay? So when you take your fixture level impressions or when you deliver your final abutments, take the x-ray. The new implants are great. They snap right in. You can feel it. But you know what? Take the x-ray. You know, just do it. It's the right thing to do. Okay? It's really important. And make sure you do them right so that you don't have this situation where on an angled x-ray, those look seated. I mean, I don't know how they look seated, but he said they did. So it is what it is. And we had to redo those crowns for the patient. Luckily, nothing happened to the implants. But that is a major food trap. You would never seat that crown in your patient with that big open margin like that. You don't seat them on your implant patients either. All right, the biggest test for implants, mobility. If they're wiggling, you got a problem. Teeth have classifications of mobility, all right? I'm going to ask, who's another hygienist in the room? Oh, actually ask the dental students. Phil, I'll ask you. What are the classifications of mobility you learned in dental school? Did you learn about classifications of mobility for teeth? Yes. Typically type 1, type 2, and type 3 mobile, correct? Type 1 is it wiggles about 1/2 millimeter each way. Type 2, 1 to 2 millimeters. Type 3, you can take it out with your finger and it's depressible, correct? Implants have mobility as well. The bottom line is if an implant's mobile, though, unlike a tooth, you got a problem. Okay, so if there's mobility in an implant, that's the biggest telltale sign that there's an issue. Now, is it the implant or is it the implant to abutment connection? So that's where you have to determine what it could be. Okay, just like it says here, the implant mobility can occur at the abutment prosthesis connection, and it could require repair. If the implant's wiggling, then you got a loss of osseointegration. You got to replace that implant. All right, and there is a mobility scale by Mish, 2008. No mobility. I don't know why he did this, because if it's mobile, you got a problem. So the bottom line is it shouldn't wiggle at all. Okay, but you can have a little bit of mobility there, and it's not a good thing to have. All right. We talked a little bit about probing earlier. We're going to get more into it now. The reason probing is not the greatest thing in implants is because we talked about the size of the abutments can really skew those probe depths. If you have a 4 millimeter abutment, you know, the margin's 4 millimeter, the implant's 5 millimeter sub G, you're going to get a 5 or 6 millimeter probing depth. The other big issue is it's really hard, depending on the implant prosthetic design, to get an implant in, get the probe in straight. So you can see that probe's going in at about a 45-degree angle, which is going to give you a false reading. So probing is important to determine if there's bleeding and there's exudate coming out with the probe, but it's not the tell-all, end-all. Mobility, the radiographic assessment, those are the big things for the implant assessment. All right? Okay, I had to have a Steeler reference in here. Jack Lambert. For football fans, Jack Lambert was a Hall of Fame linebacker for my beloved Pittsburgh Steelers, and he was missing teeth. I actually wrote to the Steelers saying I would love to place implants in his mouth, but I think he has a partial or has implants now. He didn't respond. But I just thought it's a cool picture. I have that in my office. I think it's kind of cool, to have a picture of a guy, one of my idols growing up, no teeth, kind of cool. There's some Chicago references later on as well, so just I do have some love for Chicago as well. But for those of you who know me, the Steelers are my pride and joy. Raj is shaking his head because he's a Bears fan. I'm sorry. I know they don't win like this. Okay, I'll stop right now. But health skill for dental implants. We talked about the health skill for teeth, right? We talked about the fact that you can have teeth that have different prognoses in periodontal therapy. Jim, when we talk about periodontal maintenance, hi Jim, we talk about different levels. There's excellent, there's good, guarded, poor, fair prognosis, and hopeless prognosis, correct? With implants now, we have a health scale as well. And this is what you guys got to realize. Implants and teeth are pretty similar. We're going to talk about what you can expect following implant therapy and when you need to worry and when you need to just watch. All right, and that's where this health scale comes in. So based on the assessment, we're going to determine different types of classification for implants. All right? So we have successful, which is perfect. We have stable, which is good. Compromise, which means some work needs to be done. And failed means you got to replace it. All right? And this is all based on the ICOI. All right. Successful implants. This is perfect. Implants placed, beautiful keratinized tissue, nice ceramic abutment, beautiful all ceramic crown. Great result. Bone loss down to the first thread at best. No mobility, no pain. Less than 2 millimeters of radiographic bone loss. No history of exudate. In an ideal world, this is what we want for all of our patients. We want this for all of our crowns. We want this for all of our bridges. Everything's perfect. But there's ideal and there's real. In reality, we don't always have that. So we may run into issues, okay? A lot of times, you'll get a patient that has had an implant and 2 to 3 years later, you may notice something like this. You've got a little bit of bone loss that's taking place, okay? Now, down to one thread, 1 or 2 threads. You may see some recession, okay? Now, this is the same patient, all right? I use this slide here, because I'm going to call on some people here, all right? I'll call on the dental students because they learned about this. I'll ask Phil, just because I know Phil. I don't know your other guys' names as well. In dental school, if you placed a crown on a patient, and I believe that's the facial aspect of tooth number 19, all right? A year later, the patient returned for a routine checkup, all right? And the gum had, or 3 years later, let's say, and the gum recessed, okay? A millimeter or so. No pain, not a cosmetic concern, no mobility, no bleeding, no exudate. Tooth seems stable. What would you recommend in that situation?
Probably just watch it and see if anything like that comes up.
Correct, right? So we all have patients that have recession, and sometimes the gum will recede around a crown. The natural tissue in the mouth doesn't like fake stuff. It doesn't like it doesn't like metal from crowns. It doesn't like all zirconia. It doesn't like composite fillings. It doesn't like amalgam fillings, and it doesn't like implant crowns like it likes a natural tooth. So sometimes these local irritants can cause recession to occur around a tooth, and we say, okay, let's watch. We inform our patients that there's a situation that's possibly developing. We document in our charts that the patient has been informed that the situation is going on, and we look them to see at the next hygiene appointment 6 months or 3 months later, is it getting worse? If it's getting worse, we know it's an acute problem. If it's stable, we inform them and we just watch. So if you see an implant patient and a year later they've got a little recession, and 2 years later it's the same recession, no changes in the x-ray, no changes in no pain, no bleeding, keratinized tissue present, and no acute symptoms of recession, we just watch. This stable implant that has 2 to 4 millimeters of bone loss, has no mobility, has no pain on function, or no history of exudate, has a good to very good prognosis. That means it's going to last them a long time. We don't need to freak out about that, and that's what we need to realize. People go dentists, hygienists call me all the time saying the threads are showing, the collar of the implant's showing. You know, and I tell them, I'm like, is it stable? Send them over, we'll take an x-ray and we watch. We don't have to do treatment all the time on this situation. Now, if this is number 8 and it's an aesthetic concern, we deal with it. But in the back, on the facial aspect of number 19 or number 30, in a non-cosmetic area with no pain or discomfort for the patient, we inform the patient, we let them know there's an issue, and we say we're just going to watch it. There's ideal and there's real. In reality, we're going to have this, and it occurs to the best of us for our perfect crowns, and it occurs to the best of us when we place implants. We don't know why, it just happens. You know, determine the cause of it. Is it overbrushing? Sometimes this patient was overbrushing. He had a hard toothbrush, and he was overbrushing. And that was the cause. We wanted to switch him to a soft toothbrush. So determine the cause, monitor, watch it. It's not the end of the world is what I'm trying to say, and that's what the science says. All right? Now, this patient has a compromised implant. It may or may not have some sensitivity or soreness. Once again, the big key is it's not mobile. It has more than 4 millimeters of bone loss, but still more than half of it is in the bone. All right? It's got a probing depth of greater than 7 millimeters and may have a history of exudate. If you got all those symptoms, but the implant's still solid, we can work with it. We don't have to just take it out and go crazy. And we'll talk about how we fix this in just a couple seconds here, okay? Now, this implant, you may have heard the terms ailing or failing or stable, all right? This, I consider this an ailing implant. It's stable, all right? Class 2 in the MISH scale, all right, which is satisfactory survival. It's an ailing implant. We know there's an issue with it, but it's not the end of the world. We watch it, all right? This is a failing implant, which means there's an acute problem that's developing, but it hasn't failed yet. There's a difference between failing and failed. Failed means it's about to fall out of their mouth. Failing means there's an issue. This is called peri-implantitis. We're going to talk about these implant problems in a second, okay? The bottom line is we can fix this. We can work with this. And if it never gets any worse, and we may not be able to regenerate the bone, but if that bone level stays the same, and there's no bleeding, and there's no tissue exudate, we don't need to put the patient through crazy trephiting out the implant, replacement of surgery. We can patch this. We can work with this. It's just, it's not ideal, but it'll work. Okay? Any questions on that? And we'll talk about how we fix this in a second, but I just want to classify these things. All right?
Can you do the bone grafting?
We do bone grafting on this, and we'll talk about that. Give me your 10 slides, we'll talk about how we fix this. Right now, we're just classifying the problems, and then we're going to talk about how we fix those problems, okay? This one is when it wiggles. If it hurts and it wiggles, basically if the implant moves, it's got to come out. You can see on the x-ray, advanced bone loss. Determine the cause. We'll talk about later, one of the leading causes of implant failure following integration is occlusion, all right? So this crown was made, and there was excessive occlusal wear on the crown. And that caused bone loss and eventually led to the failure of the implant. In this case, all you can do is extract it and replace it. We'll talk about that, okay? We take it out, we bone graft it, we place a new implant. We'll show you how we do that. All right? So does everyone understand the classifications here of how we classify implants? All right? The health scale. Successful or optimal health, satisfactory survival, which is a great prognosis. Just watch it, inform the patient. Compromised survival, which means we may have to do something. The surgeon or you as a general dentist, okay? We'll talk about the different areas of who gets involved, or the hygienist, okay? And then the failing issue where you get it back to your surgeon and you got to replace it, okay? Questions, comments, concerns? All right. So now that we know how to evaluate an implant, now we know how to classify these implants. What are some of the big problems that we see in implant dentistry? All right. First one is peri-implant mucositis, peri-implantitis, fractures of different aspects of the implant, mobility due to the screw getting loose, mobility due to the implant failures, and then we'll talk about what causes implants to fail. What are the bugs that are in there that caused a failure? First one is peri-implant mucositis. Okay, I'm going to call on a hygienist in the room. So I need a hygienist. Is there a hygienist in the room? There was a Michelle back there. Michelle? Right? All right, I'll call on the other Michelle. All right. If you see a patient that came to your office as a hygienist and they had a gum abscess, popcorn kernel got caught between 19 and 20. All right. You took an x-ray. The tissue was swollen. You took an x-ray. No evidence of bone loss. All right. How would you treat that as a hygienist? Yeah, what would you do? It's a little gum abscess, a pericoronal abscess. and it was a popcorn kernel. They said, I had popcorn last night, my gum's a little tender. I'm seeing you today, I'm glad, can you help me out? You would show the dentist and probably, would you maybe scale it out? Yeah, take a scaler, maybe deliver a little anesthetic, scale it out, take that irritant out that caused the gum to swell up, right? It's pretty straightforward. I mean, we do it all the time. That's something you would feel comfortable doing as a hygienist, correct, Michelle? Show your dentist, inform the patient, maybe deliver a little local anesthetic, and take your curettage instrument, your sickle scaler or your Gracie scaler, your Younger's good, and get underneath there and pick that popcorn kernel out, and that would usually relieve the discomfort, correct? Does everyone agree that's what they do? Right? Okay. Well, peri-implant mucositis is the same thing. You get a popcorn kernel, sunflower seed, some local irritant's going to get underneath the gum and irritate that implant, okay? And here we can see a patient that had a fixed prosthetic appliance. All right, here's the patient that had an implant on number 8, no bone loss, but the tissue was a little irritated. Tony, we just had a patient that had a situation like this, didn't we? A little irritation of the gum, local irritants get underneath it. We just cleaned it out, no bone loss, the implants look great, correct? So we informed the patient, do a better job with your home care. We can just mechanically get in there and clean it out. The key to this is there's no evidence of bone loss, so it's not up. We classify this as mucositis or a pericoronal abscess. All right? Periodontal disease is when you lose bone. So the next topic that we're going to talk about is peri-implant. Okay, treatment options. We already talked about this. I apologize. So what do? Michelle was so eloquent in saying you inform the dentist, maybe deliver some anesthetic, mechanically clean out the instrument with a plastic instrument. Now, Gordon, you guys, we talk about implants, metal instruments, plastic instruments, okay? You guys sell plastic instruments for implants, correct, through Nordent?
Nordent actually sells titanium.
Okay, you have titanium ones that you can clean the implants with now, correct?
Right.
Okay, so you have implant instruments, correct? So there are implant instruments. You need to talk to your reps, your 3M or Gordon, and talk to your different vendors that can talk to you about implant instruments to clean, because you don't want to scratch up those surfaces if possible. They also have Cavitron tips that are made of a composite material. So you can actually use a Cavitron around implants now with a different tip. It's a composite tip. So talk to your vendors. Talk to your Patterson rep. Talk to your, Gordon. Talk to 3M. Talk to the different vendors that you work with about getting these plastic instruments or these composite instruments to work around the implants. Number one. All right? Shoot, wrong button. Clean it off. Sometimes you can irrigate with Paradex, okay? Maybe deliver local Paradex, okay? Irrigate out that area. Maybe deliver Arestin, all right? Or a local chemotherapeutic in the site. Consider systemic antibiotics if necessary. The big thing is get them back a couple days later, check it out, and get them back one more time for one more checkup. See them a couple times, make sure the issue's handled. Exact same treatment you would do if you had a gum abscess, all right? Or a pericoronal abscess of the around a natural tooth, okay? Difference is use a plastic instrument or an implant instrument, an instrument made to treat around implants, okay? The next thing that we deal with is peri-implantitis. When that popcorn kernel stays underneath the gum and isn't removed, peri-implant mucositis will now become peri-implantitis because now the bone levels are getting irritated, okay? So what we'll see is, typically you may have food, you may have a remnant of cement, okay? And now you're going to get a little bit of bone loss, okay? The bone levels are starting to decrease, okay? So, number one, write this down. The most important thing you guys can do, no matter what the problem is, determine the cause, all right? Is it a popcorn kernel? Is it a spicula cement? All right? Is it plaque from lack of proper home care? Okay? Is it occlusal? What's causing the problem? What's causing that patient to have a gum abscess that's now getting into the bone, or just a gum abscess that's related solely to the gingival tissue? Always determine the cause and effect, okay? Too often, we worry about the effect of a problem without worrying about the cause. So we've got to always treat the cause. Peri-implantitis is basically peri-implant mucositis with the bone component, where the bone is infected. The alveolar support is now the alveolar support of the implant is now compromised. Okay? So here's a case. It was actually this slide over here. Patient presented. There was a little bit of cement that was left. All right? This is a composite cement. We typically recommend Fuji for our implants because these composite cements are tough to get out. So we flapped it. Dr. Jane, you so asked, can we graft this situation? Yes, we can. How do we treat this? Well, number one, typically you want to get the surgeon involved in this instance, okay? If you place implants, you got to know how to fix them, guys, all right? The dental students at the table were talking to me. It's a hot topic. Everyone wants to place implants. People have come and watched me place implants, all right? They say, Dr. Singh, you just put in 3 implants in 15 minutes. There's you know, and the patient's out that night having dinner, no pain, no discomfort. It seems like such a simple procedure. It's so profitable. You got to know how to treat the problems, because if you don't, then you're not doing a good job for your patients. So, yes, placing an implant's easy, but you got to have the knowledge as an implant surgeon, whether you're a general dentist, endodontist, prosthodontist, periodontist, oral surgeon, on how to prevent the problems, how to fix the problems, and how to, you know, make sure that this implant can stay in the patient's mouth. And that's why it's important not only to learn how to place it, but learn how to fix it. Questions, anything? All right. So we flap it. We determine the causative, which is this remnant of cement. Debride it out, okay? Irrigate with citric acid. Then irrigate, I apologize. Soak citric acid, cotton pellet and citric acid, and condition the roots, the surface of the implant. We then soak a cotton pellet in a doxycycline or tetracycline solution. Condition the surface of the implant. So we first clean it with an acid etch. We then condition it with tetracycline. Okay, irrigate with Paradex. Now it's nice and smooth and clean. All right. We then place a bone graft. I like to use Mineros, which is a nice Mineros is a allograft, okay, which is human cadaver bone. There's 3 types of grafting material that we use. There's a xenograft, which is from a different animal, cow, bovine, which is like biowas. There's an allograft, which is human cadaver bone. I use Mineros, which is a great product. It works really well in my hands. And then you can also use the patient's own bone, which is an autograft. And then there's alloplastic materials like Perioglass and stuff. There's science behind them. I don't like using it. You know, it just doesn't work well for me. So I prefer an autograft or a xenograft or autogenous bone if the patient allows you to go to another part of their body. But I've had really good results. This is actually Mineros here. We then place a membrane, and this is a different case just showing membrane placement. I use a Memlock membrane that I get from my BioHorizon reps, okay, and this is showing the bone graft, and the bone graft is actually hydrated in the tetracycline rinse as well. And then place a membrane over it and close. Okay, so full thickness flap, clean out the infectious or the irritant, soak gauze in chlorhexidine, tetracycline, remove the gauze, wash with the tetracycline solution. Not in here that I do is I condition with I also use citric acid as well. Then I do the chlorhexidine and the tetracycline rinse. I then graft with the surgeon's choice. I told you what I like to use. Some of you guys may use some other stuff. That's fine. Whatever works well with you. And then apply a resorbable collagen membrane. There's different types of membranes out there. Always, 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 in my opinion, the new membranes are great. Use resorbable. Don't use those Gore-Tex membranes anymore. They're tough to work with. The new stuff holds the tissue back, gives you great graft containment, prevents epithelial ingrowth, and you will get great results with these new products. The products they had 10 years ago, 15 years ago when I was a resident aren't as good as what they have now. These Memlock membranes that I get from BioHorizons are unbelievable. They're user-friendly, and you don't have to open up the patient for a second surgical procedure. So resorbable membranes is what I recommend. Any questions on how to treat peri-implant mucositis? Any questions on how to treat peri-implantitis? All right. The next issue is fractures of different aspects of the prosthesis, all right? What did we talk about the difference between a natural tooth and an implant? The biggest difference. We talked about what? Dana? The PDL, right? Yeah, so a natural tooth, when I went over the lecture yesterday, Dana's like, wow, you sound so smart. Because she doesn't see the smart side of me ever. She just sees me kind of going nuts at the office and doing surgery or sweat and just running around. But when you don't have that shock absorber, that PDL, and you bite, okay, these components are made. They make thousands and thousands or millions of these components are made. Number one, always work with the good product. There's a lot of knockoff companies that you can get from China and overseas. Work with the company that's going to stand behind what they do. One, all right? And two, that does testing on these products, okay? I've been to the headquarters for Noble Biocare, and I've been to the headquarters for BioHorizons. If you hadn't had the opportunity, you're ever out in the Newport Beach area or ever out in Alabama, Birmingham, Go see this headquarters. You got to see the testing these guys do for these products. That's why we work with these products with your patients, because they put these products through good testing. But if you don't, and you work with knockoff products, all right, you're going to have issues where the screws fracture, more than likely, and you're going to have issues where the implants actually fracture, all right? So if the screw fractures, all right, there's actually a screw retrieval kit. It's very difficult to do, all right? I've done probably 50 cases in my life, and I think about 45 of them I was able to get it out. There was about 5 of them I just couldn't get, and you had to remove the implant. You know, it happens. It's not the best thing, but it does happen. You got to be prepared for it, okay? All right? If you can't get the screw out, you got to remove the implant. But if you can get the screw out with the screw retrieval kit, then you just take a new impression, fabricate a new abutment and crown. If the implant's fractured, get it back to the surgeon. You're going to have to try to find that implant out and replace it, okay? The other aspect of the implant that could fracture is the abutment. Here you can see the implant abutment cracked, okay? So your options then are see if you can tap that crown off, because you should be cementing implants with a good semi-permanent cement, I always call it. Fuji, IRM are great. You want to be able to have retrievability. But I know the way it goes. Sometimes you can't get those crowns off. If you can't, then what you got to do, and we'll get into this in another slide, you're going to have to make an endo-access hole through the implant. All right? You're going to have to get down to that abutment. Remove, drill very carefully. Don't drill too deep and hit the head of the screw. If you hit the head of that screw, you're really up the creek without a paddle. All right? Because now that thing's going to be burnt out and you can't grab that screw. Now you got deep problems. You got to take that implant out. So very, very carefully, make the endo-access hole through the crown like you would for a root canal. Get down that chamber. All right, and I'll show you another slide, I believe, where we show you how we do that on an actual patient. Remove the cotton pellet and unscrew that implant. All right? It's what you have to do. The reps will walk into your office and kind of walk you through it. It's a tough thing to do. That's why I recommend working with a surgeon that's done this a lot. I've done lots of these. Not lots of them, but I've had good successes on these. I've done hundreds of these where the abutment's loose or the abutment's fractured. We got to get it out. But you got to be careful with this, all right? Write this down. Do not be aggressive and hit the head of that screw. That's the big problem. In the same way that if the abutment's fractured, a lot of times if that abutment isn't torqued, all right, what you'll have is the abutment to implant interface is loose, so you'll feel like the implant's loose. Now, there's a thing you can test for. The mobility feels like clicking or popping when lifted and wiggled horizontally. If it's the implant, the whole thing's going to move and they're going to feel pain in the bone. If it's the abutment, the pain is typically localized to the gingival tissue right around the implant, and you'll actually hear a click, click, click when you push and wiggle it. That's the way to tell. If pain's in the bone and an x-ray shows major radiolucencies around the implant, it's typically the implant. That's why it's loose. Refer it back to the surgeon. You got to get it out. If you feel a click, click, and the x-ray looks good, it's typically the abutment. All right? So the Jew, as the restoring doctor, can treat this. All right? So first try and tap off the crown and retighten, then expose the get the crown off, as you see here. Remove the cavet or composite or firmament that seals that screw access hole. Retorque that implant down. Reseal the screw access hole and re-cement that crown. If you can't do it, this is an actual case I did. You got to make that endo access hole, get the cotton pellet out, retorque, and then seal that top of that endo access hole, I call it, or the screw access hole through the crown with cotton pellet and then some sort of composite material like you would through a crown for an endo tooth. All right? Make sense? All right. This is pretty straightforward when you've done like 50 to 100 of them. It's not the easiest thing when you do your first one. Call the reps in. They've been, I mean, Scott, Mark, have you helped guys out doing this? All right? And you've got special tools and you guys can help them out with this stuff. Right? So, I mean, it's why they're there. It's why we work with good products. You know, like a lot of these knockoff companies come knocking on my door. Doc, you can buy the implant for half the cost. And, you know, it's the same product and it's an exact duplication. I don't work with them for the very reason I'm paying extra for my implants because of the way they're made. The testing they do to make sure that this stuff doesn't happen. I mean, I just had dinner. Brainard, Jim, and I were at dinner in Toronto with one of the regional manager for all of Canada for BioHorizons, and they were talking about the research they put into the designs of the screws so this doesn't happen. It's unbelievable. I mean, it's the same research that NASA does so that these screws don't loosen. That's why you got to work with these good companies because there's so much research with these unigrip screws that Nobel makes. And the, Jim, what was the word that they used for the screw, Scott? The NASA screw, it's called? What's the, spiral lock. I mean, I literally, I talked about a screw, for half an hour. I mean, usually you're drinking and having a drink and you're talking about screwing in a different way. That was my joke for the day, but okay. But we talked about screwing at dinner with the female BioHorizon regional manager from Toronto. Great. But it was amazing. It was a great topic, and it's why you want to work with a good company. Because the last thing you want is these screws to come loose on these knockoff products. Marcus, how can I help?
Another question. Do you know off the top of your head if there's any requirement, like FDA requirement for, foreign implants coming in?
There's a lot of loopholes to get these things in. They do have to be FDA approved, but the testing is just, I'll put it to you this way. You know what? You can buy a car, like a Yugo, right? And you can also buy a Mercedes, and there's just a difference. They're both cars. They're both made overseas, but one's just better than another. You just feel the difference. And when you work with these knockoff products that are made for half the price, they're going to tell you, oh, save money. They work the same. They're an exact duplication. They don't have the testing, and I've been to the headquarters for BioHorizons and for Noble Biocare. I mean, it's unbelievable the testing that they put these implants and each component through. It's great,
So they have to get FDA approval.
They do have to get approval, but there's a difference between getting approval and actual standing behind it and doing it right. So yeah, I think it has to be approved if they're going to sell it in this country. But what you're paying for is the support, the research, the fact that you can go out to these companies and it's done right. That's why I mean, look, I do a lot of implants. I can make a lot of extra money in my pocket if I bought these knockoff products. And I mean, I'm not here to talk about different implant companies or whatnot, but I pay for the best, because I want the best into your patients, and I don't have to deal with these issues, But that's what I say. Literally, I come in and I'm dealing with this stuff, and I'm like, this is ridiculous. I mean, the stuff we deal with because of these products, And I mean, I don't have these problems when I use a good product that's a top 5 product and it's restored properly. You don't have these issues, okay? Look, if the implant's failing, all right, like here, there's threads down, here's the crown, you got a problem. You got to remove the implant, you got to put your mineros in, bone graft with the membrane, all right, wait 3 to 6 months, replace the implant, wait another 3 to 6 months, put a new abutment and a new crown on, all right? I mean, that's what you got to do. So if you have an implant that fails, get it back to the surgeon. Implants do fail, all right? Success rate nationally is 95%, okay? That includes everyone under the sun that does implants. That's nationally. In reality, all right, and all these studies were done on perfect candidates, non-diabetics, non-smokers, and that's where these success rates came. In reality, we deal in the real world. You're going to have smokers, you're going to have poor oral hygiene, you're going to have people that aren't taking care of things. So in reality, the initial success rate is going to be 95%, but if they don't take care of it, you're going to run into issues down the road. So in reality, if you do 100 implants, you're going to have a success rate of about 92 to 95%. All right? And not because of the failure to integrate, because there's issues on the back end. Okay? Does that make sense? All right? So be prepared for this. Implants are coming, and they're the hottest topic in dentistry, and they're growing, and everyone's talking about them, and everyone's doing them. Vic and I were talking, there's big implant centers out there, and they're talking about teeth in a day, and come on in and see us, and we'll take out your teeth and put brand new teeth in. I'm getting calls from, I'm a legal expert. I give my expert opinion, because I do a lot of implants. And a lot of these big chains, and you can tell your patients this, we can give you brand new teeth, and they're going to look great. What kind of maintenance are they offering these patients? I mean, they don't even have a hygienist at these chains. They're saying, yeah, come on in, give me $50,000, I'll give you brand new teeth. Hasta luego. Now go back to your dentist, and maintain it. I mean, that's not the way it works. As a treating surgeon, you got to stand behind what you do. Jack and I were talking about this, and it's kind of a sticky situation because in school they haven't talked about it. You didn't learn it, but Jack says he wants me to see the patients. All right, Jack? I mean, if I put 6 implants in a patient of his, I got to look at this. I got to maintain it. There's a reason they lost their teeth. The number 1 cause of tooth loss in the world today is what? Everyone knows. What is it? Gum disease, right? You know, that's basic dental school 101. Usually if you lose a bunch of teeth, you've got a problem. You got to maintain it. So, I mean, you've got to stand behind it and you got to watch it. And if you're doing implants, you got to make sure that you maintain them, okay? All right, and we're going to talk about that in just a couple seconds. So if the implant fails and it's mobile, determine the cause of the failure. Occlusion, poor oral hygiene, local irritants such as cement or popcorn kernel or whatever it could be. Figure out what caused the failure, and then you can replace it. I've done 8,000 cases, successfully placed over 8,000 implants. I've had 2 patients that I could not make implants work on in the long run, all right? One was a man that became a woman, so I placed 4 implants, 3 worked, replaced the implant twice, could not get it to work. All right, I think there was hormone issues, and unfortunately there's no studies on men becoming women or women becoming men and hormone changes and how it affects implants. Just not enough out there right now. But I had a feeling it had something to do with that. And the second patient had bilateral kidney failure. So they were in, it was working, and then everything went, the whole body shut down. So there's usually a cause. 99% of the time, if there is a failure, it occurs within the first 12 to 18 months. After that, you're usually in the clear as long as they maintain it. All right? So if that implant's in, it's in for a year, and they maintain it with the recommend, and then they follow through with the recommended maintenance that we recommend, you're going to be good, all right, for 20, 30 years, 25 to 30 years or a lifetime. All right. I got to call on the dental students here, all right, because, I mean, this is the stuff that they're learning. All right. Porphyromanus gingivalis, Prevotella intermedia, Fusobacterium nucleatum, all right. This is Iancono 2000. These are the same bugs that, when you have a failed implant, these are the 3 periodontal pathogens that are found around a failed implant. Those are the same periodontal pathogens that you find in patients with periodontal disease, correct, guys? That's the board question, right? Right? PI, PG, and FN. That's how I remembered it, all right, when you get your multiple choice question. So when you have a failed implant, you have the same bugs that cause periodontal disease, all right? Hence, you have science that says you should take x-rays every 3 months in the first year. You have science that says the leading cause of implant failure is a local irritant, such as plaque or cement, or that can cause the bugs to build up. And these are the same bugs that cause gum disease. Hence, these findings will support our recommendations that patients with implants need to be on a regular schedule to monitor their maintenance, which includes plaque control of the implant-supported prosthesis, all right? Bottom line, it's the same bugs that cause bone loss around teeth cause bone loss around implants. And based on that, we need to take care of these things. And it's common sense, guys. If the patient's going to make a $20 or $10 or $5 or $10,000 investment to replace their teeth, you know, you want to make sure they you stand behind what they do and give them that insurance policy. The guys in the back, we sell life insurance, we buy it all the time. Because God forbid something happen, I want to make sure my kids have something there for me. We buy auto insurance. It's an insurance policy to make sure your patients that have made a big investment in their oral health and in the overall quality of their life, all right? This is an investment they're making to improve themselves. You want to make sure you stand behind it. And how can you stand by? You can't stand behind it and guarantee it if you don't take care of it. All right, so hence, you got to have maintenance for these implant patients. All right, so let's talk about the preventative measures, all right? How do we prevent these problems from occurring? All right, everyone doing good? Dessert was served? Raj, did you get extra dessert? I know you like 2, 3 pieces of cake. Okay, I had to tease you a little bit. Yeah, Raj was like Mike. He ate everything. It was good. So he likes the dessert. I like dessert too, so it's my favorite part of the meal. So I'm hoping they saved some cake for me. It looked good. Preventative measures. All right, so first thing we'll talk about is that insurance policy. How do we ensure we don't have problems with implants? When we went back to one of the first slides, we talked about the fact that the difference between a tooth and an implant is the implant does not have that shock absorber, that PDL, the periodontal ligament fiber. Hence, it's very brittle. People with implants will get TMJ, all right? If you have a lot of implants, if you have 2 or more implants, just put them in a night guard. If you have an implant, I say put them in a night guard, just 1 implant. You prevent porcelain fracture, you'll prevent screw fracture. It makes sense. I've had full mouth cases. Jim, we had that patient. We did full mouth reconstruction. She had a full upper denture over an implant-supported removable overdenture. And then we placed her in a fixed over fixed implant-supported appliance. And the patient literally had to go to a neurologist because of the TMJ issues. You know, remember that case, Jim, that we did? It was a full over full case. And, you know, it makes sense. The teeth give. People in dentures, they give a little bit. The dentures give. They wiggle, they wobble. Now you put them into something fixed. You need to inform these people. Yeah, we can take out your teeth and put brand new teeth in the same day, and it's going to lock in and it's going to look great. But you have to tell these patients it's going to be a little different than natural teeth. It's never the same. When you put a denture into a patient's mouth, you inform them. You manage their expectations, all right? That's important. Write that down. Manage the patient's expectations. If you manage your patient's expectations, you can avoid a lot of problems on the back end. So if you do a couple implants, give them a night guard. Work it into your feet. Charge them. It doesn't matter. Get them a night guard, all right? It's going to prevent so many problems that you will deal with on the back end, okay? The most common cause of both early and late implant failure after successful implant fixation is a result of parafunction or occlusal trauma. What that means is, once that implant's in and it's fully integrated, you've done a torque test and it's good, if it's going to fail, the number one cause of failure is because of occlusal trauma. So put them in a night guard. It costs you, $50 to $100 to have the lab make it. Work it into your cost of your prosthetic appliance if you don't want to charge the patient, or tell them they got to have it. It's just what they have to do, all right? If they have 4 quadrants of osseous surgery, we all tell them they got to have recalls every 3 months, right? That's ingrained into our heads from what we learned in school. Same thing. If you have implants, several implants, full mouth reconstruction, get them into a night guard. It's going to avoid a lot of problems, okay? Patients with so here's our recommendations. We get 1 or 2 calls a week on what we recommend for our implant maintenance, okay? All right. So patients with implants should be evaluated at regular intervals to monitor the peri-implant status. We talked about that. Evidence suggests that plaque control is critically important for the maintenance of dental implants is equally as important for both implants and natural teeth. All right, so evaluate the implants at the normal recall appointments, okay? We talked about how to do that. Every patient is individualized, the recommendations. How do you individualize those recommendations, okay? You look at the classification, all right? Do they have type 1, type 2, type 3 periodontal disease? The severity of the case, the stability of the disease process. Consider the health history, contributing factors, smoking, uncontrolled systemic problems, poor oral hygiene, talk about issues with arthritis, inability to properly clean, having dexterity issues. Take all that into consideration, all right? Look at the autoimmune issues. Look at the systemic issues. Take all that into consideration. And then, in general, this is our recommendation, okay? If they have 1 implant, they need to see the dentist twice a year for regular implant, just a regular cleaning. Take your x-rays as needed. If you have 2 to 3 implants, we recommend in our office, okay? Taking everything into consideration. Now, it's specific for every patient, but this is a true 95% of the time. See the dentist twice a year and see the surgeon once a year for cleanings, all right? So 3 times a year, alternating 4-month recalls, okay? 4 more implants, 95% of patients that have 4 more implants have lost their teeth due to advanced periodontal disease. Hence, alternating 3-month recalls. And there's studies that will support if you have 4 more implants, usually you've lost them due to advanced periodontal disease. Hence, you need to control the periodontal disease, and you got to maintain it with alternating 3-month recalls. That's a good guideline to go by, okay? If you do this, you can stand behind what it is that we say we can guarantee. If they don't do this, okay, and they don't take care of their mouths, how can you guarantee it? A cardiovascular surgeon is not going to guarantee the heart surgery, all right? If the patient comes to them and they smoke, they're 100 pounds overweight, they eat McDonald's every day, they do drugs, they drink, the cardiovascular surgeon is going to say, you've got to change your lifestyle, and then I'll give you a new heart, all right? Dentistry is the only field in medicine where we're held to such a high level, high standard. I mean, you put a bridge in, it's got to last a lifetime. You put a denture in, it's supposed to, the teeth aren't supposed to crack. The teeth aren't supposed to stain. You have cancer treatment, you have a $100,000 medical bill, and the patient dies. It happened to my uncle last year. He was in the hospital on life support. They put him through God knows what, chemotherapy, radiation therapy. He shrunk. He was horrible. He ended up dying. But no one questioned the doctors, okay? In dentistry, we do work all the time, and patient comes back 3 years later. We've placed an implant. We've done a beautiful restoration. They don't show up in the office, and then they get peri-implantitis. They get gum recession. The threads are showing, and we're supposed to stand behind it, and guarantee it for a lifetime. It doesn't work that way, guys. We don't do it for our patients if they don't show up for their recall appointments. You have to inform them. If you have implants, you've got to maintain it. Otherwise, how can we stand behind what we do? And not only is that the right thing to tell the patients, they sign consents on it, but legally it's the right thing to tell them. In the court of law, that holds up. So we can stand behind these things. Look, I'll stand behind an implant all day long if the patient maintains it the way they need to maintain it. If the thing cracks because of a crazy situation, I'll take it out and put a brand new one in, all right? If they come to our office twice a year, or they see you guys twice a year, or they're maintaining it properly, they have good oral hygiene, and we instruct them and they're doing what they need to do, we stand behind it. But you can't expect any of us in this room to stand behind what we do, whether it's a root canal, a bridge, a crown, a denture, if our patients aren't doing their part. Does that make sense? Does everyone agree with that? Does anyone have any comment? I mean, it's common sense, right? You know, and that's why it's important that when we do implants that we stand behind what we do with maintenance, okay? So, look, if a patient comes to me with 4 congenitally missing premolars at orthodontic treatment, we place 4 implants, they don't necessarily need to do alternating 3-month recalls. That's an example of a case who, and Mira could attest to this, you have pediatric patients that are born without teeth, you give them implants when they're 18 years old or 15 years old, whenever, they don't need to do alternating 3-month recalls. That's an example where that's the 5% rule. But the majority of the time, you got 4 implants, alternating 3-month recalls with the surgeon. Okay? Instrumentation, all right, for the hygienist in the room. Implants are like natural teeth. Treat them that way with the one difference, you don't want to scratch the implant surfaces, so use these implant instruments. Gordon says that they've got plastic instruments and they've got titanium instruments that are meant to be used around implants. Get them so you don't scratch up the surface area so bugs don't build up on the area. All right? We've got a lot of different instruments that we recommend. The next slide is going to talk about it. But the bottom line is you don't want to scratch up the implant surfaces. Hence, you don't want to use regular, traditional, metal scalers around it. Use the plastic or the titanium ones. A lot of auxiliary aids that we recommend for our implant patients. My favorite one is right there, that proxy brush. All right? People don't use the super floss. It's too hard for them. This thing is the best for implant-supported fixed dentures, bridges, full mouth reconstructions. They can get that thing right underneath there and they can clean. So the design of the prosthesis is important to make sure that you can get something in there to clean. Okay? That's important. Super floss is great. Nobody ever uses it. If they do, more power to you. I'm just being honest. I mean, how many hygienists are in the room? How many patients use the super floss? Do they really use it or not? I mean, Karen's shaking her head. I mean, they don't do it. It's too hard to do. So the proxy brush I recommend instead of that super floss, okay? This is the best. This thing is, I literally give it away to my implant patients. I just say it's part of my fee. I just say take it. You do a full mouth implant reconstruction. You have a full mouth all on 4. They got to use that water pick. Tony, one of our patients, a good friend of ours, she had full mouth implant reconstruction on, I think, 6 implants on top. And you got to have this water pick. It's the best, all right? Now, it doesn't take the place for brushing, and it doesn't take the place of a proxy brush or a super floss, but it's a great adjunct to therapy. So, what I'm recommending here, these auxiliary aids for the hygienist, you got to teach them how to use it, and you got to make sure they still brush their teeth, all right? Nothing replaces a toothbrush, toothpaste, and floss, but these are great auxiliary aids around implants. That's why I recommend sell the water pick in your office. Make it available to your patient. It's a great product. It really helps them a lot. All right? The fluorides. Certain fluorides are acidic, and you don't want to put acidic fluorides around porcelains and around implant crowns and whatnot, so you want to use non-abrasive products, okay? We recommended a couple over here. You want to use neutral products because you don't want to roughen up the surface coatings of the implants on the crowns around those abutments, because if the surface coating's rough, you get easier for bacteria to build up around it, and that's the concept behind that. So neutral products, okay? 3M's got some products. Lindy's in the room, so she can definitely talk to you about some of that. All right? Questions on some of the auxiliary aids for our implants? Questions on what we recommend for maintenance? So what do we recommend? If you got a couple implants, night guards. All right? Just work it into the plan. It's part of the treatment plan. You have to have it once it's restored. All right? Preventative recare appointments. You've got to see these patients. The surgeon should be seeing them, okay? All right? Because if a problem develops, you want to get at it before it becomes problematic. You want to get at it when it's mucositis, not when it's peri-implantitis into the bone and we got to surgically treat it, okay? Paradex. We use Paradex a lot. It's great. Paradex kills about 90% of the bugs that cause periodontal disease. Kills 90% of the bugs that cause peri-implantitis and implant failures. The problem with Paradex is it stains, so we recommend using it with a cotton swab if you're going to use it to help maintain implant patients. Don't rinse with it. It'll stain up the teeth, build up calculus. Use that cotton swab and use it around the locators or around those implant abutments or around the abutments of your natural teeth for bridges as well. Okay? All right, I think that's about it. Here's Duncan Keith, knocked out his teeth, played in 2010 when the Hawks won the Stanley Cup. Last couple of years haven't been so good for our Blackhawks. I do like the Chicago teams. I'm a big Bulls fan as well. We lost Derrick Rose. I didn't put a picture of his knee up there. This is kind of fits the mold. And my favorite, well, thank you to all of our sponsors. I have one more picture. It's my favorite picture. Once again, thanks to BioHorizons, Noble Biocare, 3M, Care Credit, Rocket Dental Studio, Gordon Jennings, and Northwestern Mutual Financial. Please take the time to talk to these guys. They can really help you out in a lot of different ways. And last but not least, thank my wife for giving birth to my beautiful kids. This is in 2009 before the Super Bowl when the Steelers had that amazing drive and beat the Arizona Cardinals. Great game. Had two of the greatest moments in Super Bowl history with a 100-yard interception return and a last-second touchdown to win the game. I said some bad words that day in front of my kids, but they lived to survive it. And this was my favorite picture because my wife got them all dressed up, and this was my son at like 6, my daughter at 5, and my little one at like 1. It was awesome. So it's in my office. It's my favorite picture of all time. So I always show it. Show my love for my Steelers and my love for my kids and my lovely wife who gave birth to my kids. And thank you again to her for helping putting the evening together. And thank you guys all for attending. And without that, references all there. And that's about all I got for you guys. Thank you. Any questions? Anything? Yes, Dr. Schefter.
How does nutritional support fit in there? Are there any supplements that might help?
You know, I'm glad you brought that up. I mean, well, you know what? Let me just be honest and answer that question. When you go, look, I take supplements when I exercise. My trainer gives it to me, and I swear to God, it's like a drug. I think I'm addicted to them. If I don't take them, I can't work out right. When my wife was pregnant, she went to the OBGYN, and I went with her for the first kid at least, and after that, she was an old pro. She was able to go on her own. But in all jokes aside, they gave us supplements. When I had surgery done on me, my plastic surgeon, I played basketball, I had my lip busted open, the plastic surgeon gave me supplements to promote healing. So, I mean, there's science behind the healing process of the body. So I think there are supplements out there that will promote healing and improve the surgical response for our patients. So I'm a believer. We use them. I use them myself to help me with exercise.
Are there any that's been tested for dentistry?
There are certain ones that have been tested. I know that there's certain companies that are out there. I know that you have information that the doctors can talk to you about. I know you're an infomercial, Dr. Schefter, a marketing genius, and I know that the doctors can talk to you about that if they'd like. And like I said, but we do use supplements in our office, and we do recommend because it does promote the healing response in my professional opinion, and I've seen great results with it. Any other questions? Dr. Ali, any questions? Thank you for joining us. I didn't see you. You snuck right in. How are you? Great to see you. Everyone do good? Any questions, comments? Mr. Scott, can you add anything? Turned out good?
I think it's fantastic. If you actually would have people really follow up on doing what you're espousing here tonight, you might put me out of work.
No. I don't want to put you out of work, man.
It really makes the whole process go a lot smoother because, like you were talking about, that screw loosening, and that's a really tough day at the office. Mark, I'm sure would agree that we do, even though we do make those tools, you can avoid a really tough situation just by doing some of the little tricks you showed through tonight. It's very good.
Absolutely, guys. And like I said, call us. We will help you. You know, myself with Periodontal Implant Associates, you got brochures on our practice. We do complimentary implant, my infomercial now, guys. No, but we do complimentary implant consults, and a lot of you guys have those brochures in there. We have complimentary CT scanning cards in there as well. So look in the packets, review the lecture notes. Hopefully you guys learned some stuff in there. Any questions regarding your patients or regarding, possible future patients, contact our office. Dana, our lead treatment coordinator, knows more about the patients than I do. She can answer all the questions. If you can't get a hold of me, you can talk to Dana. The girls are great. Michelle is awesome in terms of educating your patients for oral hygiene. And we work with some good products. So hopefully, everyone got what they wanted out of the lecture. I know it's a hot topic, and a lot of you guys asked me to put something like this together. We'll be doing something later on in the year for more with implant dentistry here at the same venue, and it's going to be more for the staff as well. Anyone else? Dr. Spiropoulos, how are you?
If you have a screw retained abutment that loosens, should you replace the screw with a new screw, or just go ahead and reveal one?
Did you guys hear that question? Dr. Spiropoulos asked, if you have a screw retained abutment that loosens, should you replace the screw? My answer to that is, was the cause of the screw loosening the fact that the screw wasn't torqued all the way, like some dentists just hand tighten because they didn't have the torque wrench? If you torque the screw to 35 Newton centimeters or 30 Newton centimeters as recommended by the implant companies, and that screw loosens, replace it. If you just hand tighten the screw and it loosens, then just torque it. You don't need to replace it. So that's the answer.
I was told that you should have a different one when you do any kind of lab work and use the one that you actually use to restore the tooth as its own, and not to have the same.
Yeah, typically when the lab makes it, they take it on and off, and there's a lot of vibrations and stuff, so they have lab screws. Tad, can you comment on that about lab screws when you're making the prosthetic appliances?
We work only with lab screws. We keep the fixed screw.
And then you provide the doctors with the fixed screw, correct? So it's first time usage and you get the best results. Yep. Very welcome. Good to see you. Dr. Spiropoulos was my mentor when I was in dental school. She taught me a lot about dentures and tap, tap, tap. She was president of the dental school class. So she was very, very instrumental in my professional career as well. Thank you, Dr. Spiropoulos. Anyone else with any questions? Okay, 3, 2, 1, game over. All right, thank you guys. Enjoy. Thank you.